Go to full screen mode. Look good? Okay, we're going to do this in two parts. First part is the ABCs, ABCDE, but ABCs. And then we're going to talk about fatty liver. And of course, built into that, we're going to talk about elevated liver tests. And okay. So this is describing viral hepatitis A, B, C, D, E. And what I want to highlight here is that most patients, 99% of our patients who come through the clinic need to be worked up for chronic viral hepatitis. What we're seeing in the clinic is a lot of patients coming in with hepatitis acute tests that are being done, like hepatitis A IgM or hepatitis B core IgM. Those tests only have a value in the setting of what looks like acute liver disease, acute hepatitis, ALT over 200, maybe the bilirubin's elevated, potentially a recent risk factor. Otherwise, we need to make sure we're not ordering IgM tests, we're ordering total hepatitis A. We're measuring the hepatitis B triple panel, which is surface antigen, core antibody total, and surface antibody. And hepatitis C antibody test is the test first for screening for hepatitis C. Hepatitis D on here, Delta, only goes with hepatitis B. So we don't test people for hepatitis Delta unless they are surface antigen positive. And we're only going to test for hepatitis E in somebody with acute liver disease, elevated ALT, over 200, recent travel, some type of recent exposure. Really important here is we have hepatitis A vaccine. Hepatitis A is vaccine preventable. We only vaccinate people who are hepatitis A antibody total negative and no history of hepatitis A vaccination. Hepatitis B, same thing. It's vaccine preventable, but they need to have a triple panel that's negative. You never vaccinate somebody who's core antibody positive. Hepatitis C, there's no vaccine. Delta, if you prevent B, you prevent Delta. And hepatitis E, the vaccine's only available in China, maybe a few other countries. Excuse me. So we're going to move on and talk about why hepatitis B and C infections are so much of a problem. The number of deaths from hepatitis B and C is staying high, although finally hepatitis C deaths are being blunted because we have a cure. In the world, we have 254 million people with hepatitis B. Only 4% are on treatment because the guidelines are too complicated, and we should take a treat-all approach like we do with hepatitis C and like we do with HIV. So that's hopefully going to change. This is super important. Every patient who has suspected liver disease should get a full liver panel that should include the GGT. We have a lot of patients coming to see us. The GGT has not been ordered. We have to order the GGT to complete the workup. The GGT is not in the full liver panel because of a stupid mistake that Medicare and CMS made over 30 years ago. That doesn't make it right for us to ignore the GGT. Order GGT on every patient who's got suspected or known liver disease. Liver enzymes are not LFTs. They're not liver function tests. They are liver enzymes. Liver synthetic tests are bilirubin, albumin, and INR. It's very important to separate liver function from liver enzymes and be accurate in your terminology. Every patient with elevated liver enzymes, especially if you document it just twice, needs to have 6 tests. Take an alcohol history. But what's not on this slide, which I'll put in when I publish the deck, is a PEth test, P-E-T-H, hepatitis C antibody, hepatitis B surface antigen. Of course, that includes the triple panel, iron saturation, medication, herbal, over-the-counter history, and look at these metabolic tests. Really, they're pretty much in everybody's chart anyway. You've got a BMI, you know if they have hypertension, you got a lipid panel. So that metabolic panel is really considered one package in the 6 tests that are here. Back to hepatitis A. There's been an upswing in hepatitis A in California. 2015, we had 20 deaths, over 400 acute cases in San Diego County. It was in the homeless population, IV drug users. A lot of them had chronic liver disease, alcohol-associated liver disease. This is vaccine preventable. Any patient with chronic liver disease has to have a hepatitis A total test and then vaccination if that's negative. So we're very good about getting vaccine done in the liver clinic. This should be done in the primary care clinic. They should come to us already hepatitis A vaccinated if they're not immune. Anyway, this just has to do with hepatitis A transmission, lots of different risk behaviors. So let's just vaccinate everybody. It's a very safe vaccine, no issues. If people have chronic liver disease and they get hepatitis A, they have a much higher risk of getting fulminant liver disease. It's even more reason to vaccinate everybody. So hepatitis A testing, we want to get total antibody in everybody, only IgM, ALTs over 200, risk factors, and elevated bilirubin. Okay, vaccine preventable disease, we're going to be switching to hepatitis B. This gives you the number of people infected worldwide, number of people infected in the US. But 2 billion people are core antibody positive, total core, not IgM, total core. That means they have hepatitis B in their liver, they have cccDNA in their liver, they're at risk for reactivation. This is vaccine preventable. 2 people die every minute from hepatitis B somewhere in the world. Under treatment is the rule because the guidelines are too expensive, too complicated, people don't follow them, and nothing happens. Too much academics. We do tell people that hepatitis B is not curable, but it's suppressible, controllable. We can prevent cancer, we can prevent cirrhosis, and of course, it's vaccine preventable. So when we order a triple panel, we order a surface antigen. If somebody's surface antigen positive, we go on and check delta, we get a quantitative S antigen, and we get a HBV DNA test. But core antibody, super important. A lot of fake news out there. Once somebody's core antibody positive, you have to believe it. It means they've been exposed, they have a little bit of hepatitis B left in their body, and you can send them to our clinic if there's a question about occult hepatitis B. Some people are surface antigen negative, but actually have circulating virus in their blood. We're going to educate about reactivation. No vaccine boosting. Nobody with core antibody needs to be vaccinated. They've already been exposed. They already have hepatitis B in their body. And do not order core IgM unless there is real suspicion of acute hepatitis B and recent risk behavior. Anti-HBs, the third test in the triple panel, indicates immunity only if core antibodies negative and surface antigens negative. If people are triple negative, they get vaccinated. If they're surface antigen negative, core antibody negative, surface antibody positive, they've been vaccinated. There is no natural immunity. A lot of other tests we do in our liver clinic once they come to see us. But if you're going to refer somebody with hepatitis B, you should already have an HIV test in their chart. You should have a hepatitis A test in their chart. You should have hepatitis C test in their chart. And you should have a delta antibody test in their chart. The primary care providers can send those to us. We can order some of the other specialty tests later. This just gives you a box reviewing what we just reviewed. There are a lot of different phases of hepatitis B infection, but now the trend, my recommendation, surface antigen positive, they go on treatment. Everything else gets complicated. What phase are they? What's their surface antigen? What's their DNA? What's their ALT? What's their E antigen? Way too complicated. When you put that complex message out there, people don't get treated. And that's been the rule, unfortunately. Same thing in the US. 2.4 million people with hepatitis B, less than 400,000 have been treated. And maybe half of those who have been treated are actually on treatment today. DNA is super important. DNA in the Western world, we have the money, we can check it. It relates to a lot of different things in terms of response to therapy, what's their risk for cancer. But I just went to Africa, and the PCR test in West Africa is $60. Tenofovir is $2.50. So one PCR test will pay for 2 years of TDF. And if you look at everybody's surface antigen positive, 95% are DNA positive by PCR. So why do the DNA test? Well, WHO, EASL, ASLD likes to be really complicated. They like to be very academic, highest level of evidence. But if we lived our life on the highest level of evidence, we would not have stop signs. We would not have stoplights. We wouldn't have parachutes. So we test every adult for hepatitis B triple panel. Every adult has a triple panel in their chart. That's standard of care. We have 3 drugs to treat. Entecavir and TDF are quite cheap. TAF is expensive, but it's the best in terms of lowering ALT, lowering cancer risk. So when we can, we use the best drug. If we get big pushback, then we would go to TDF or entecavir. We do not use pegylated interferon today. So we want to suppress DNA. We want to prevent cancer. We want people to feel better. We want to prevent cirrhosis. We want to prevent transplant. We want to prevent death. And these drugs do all those things. But we never tell anybody it's lifelong, because we have 65 new drugs coming. And that sounds depressing. We tell them you'll be on it long-term until a new, better therapy comes out. There are many new treatments in development. Be optimistic, give an optimistic message. This is called the 5-line guideline. You test everybody for hepatitis B, triple panel, vaccinate everybody who's triple negative, surface antigen positive. You can do some additional tests, but everybody goes on treatment. And you're going to stage their liver disease. And if somebody has cirrhosis, you start liver cancer surveillance. This is really the summary. I just wrote something for West Africa. It's a little bit more complicated than this. It's got 10 lines in it. But the document I just got from Sierra Leone was 40 pages. I said, take the 10 lines, put it on 1 page right up front, give that to everybody, then they can read the 40-page document if they want to. But I'm having a conference call with them this week to modify it, because they're following WHO too much, which is not relevant to them because of the difference in costs. So hepatitis B is serious. 2 people die every minute. Every adult needs to be tested. There's a whole controversy about testing children, because most children have been vaccinated. But if you're in a low vaccine country, then children need to be tested also. And although not curable, it's suppressible. We can make people better. Don't vaccinate core antibody positive patients. Don't check IgM core unless somebody has acute hepatitis B, and it's very clear. We're going to treat everybody till they lose surface antigen plus 1 year. Everybody needs to be staged for cirrhosis. Delta, I'm not going to talk a lot about today because that's a specialty test. They'll come to us. We'll check surface antigen and go to Delta, then Delta antibody, then Delta PCR. But D is for deadly, 70% mortality rate in less than 20 years. Why we call it the deadly virus. Hepatitis B vaccine prevents. Treatment, there's new treatments coming for Delta. Hepatitis C, super easy. Every adult gets hepatitis C antibody test, antibody positive. They get RNA, PCR, they're RNA positive, they go on treatment. That's the end of the discussion. I'll click through a few more slides out of interest. Test all women for hepatitis C, of course. It's just an algorithm about testing, getting RNA testing, and then putting them on treatment. We don't do genotype. We don't do resistance testing, but we do stage their disease. We look for substance use disorder, alcohol use, mental health issues. And just like we did for B, you're checking all the other serology that's part of that package. We want to stage everybody. This is the 0 to 4. Fortunately, we don't do biopsies. We do FibroScan, we do FIB4, we do APRI, we do liver, spleens, portal vein and spleen size. So we have other ways of staging people without a biopsy. This is an epidemic of IV drug use. That's why hepatitis C has been going up, starting to come down. They go up again, depending on risk behavior. This new government we have is looking like they're going to block Hep C access by decreasing Medicaid, insurance, just a total disaster. So, yeah, this is an article in the New York Times saying we have one of the best miracles of medicine that we are not delivering to patients because of politics. This has to do with this whole program about how to get people in and not just manage their virus, but manage them as a whole patient. So test everybody, at-risk children. There is no vaccine for C. So if a baby's born to a mother with hepatitis C, of course, the children should get tested. The rule is 20 to 30% of people who are hepatitis C develop cirrhosis, but now because of so much alcohol and fatty liver, the risk in a hepatitis C patient of getting cirrhosis is probably 60%. It's doubled because of the comorbidities that are there. And we only do surveillance for liver cancer in people who have hepatitis C and have cirrhosis. We rarely start like stage 3. Mavorite, Epclusa are 2 lead therapies. One is 8 weeks for Mavorite, but 3 pills. The other is 1 pill for 84 days. That's Epclusa. Vosevi is listed here. And Vosevi is only for people who have resistance or have failed a previous standard course of therapy. Cure rate, 98%. It's just an absolute miracle. I think we've covered everything on here. Hepatitis C, not important in this country, although once a year you'll hear me asking to order a test. Usually it's an IgM test because somebody has acute hepatitis and the first level workup was negative. There are treatments for hepatitis E, specifically ribavirin, interestingly, but I've probably seen 10 cases of hepatitis E in the last 20 years. It's super rare. Okay. We are going to X out of this and go to
hepatitis B. How high would the enzymes be?
surface antigen negative, core antibody positive. That's occult hepatitis B in general. We'll check a DNA if they have any ALT elevation or any abnormality on imaging. Any signs of any type of liver disease. Sound good?
Right.
Great question. Okay, we're gonna go to fatty liver now. Sorry, go back to the beginning. Okay, any other questions on A, B, C, D, E? We're good? Did we fix everything, Elsie?
So do we have to retest our patients if there's like less than 15 detected, or just continuously monitor with like a FibroScan?
If the hepatitis B is in boy, C, if they're not detected, they don't need to be tested again because they've cleared. And that occurs in 30% of hepatitis C patients. They clear hepatitis C on their own. Say that again?
There's no risk of reactivation at any point because it's clear, they're negative.
Nobody reactivates hepatitis C. Simple rule. Okay, we're good? Okay. So we're going to change to fatty liver because everybody with elevated liver tests gets worked up for fatty liver, right? Very simple. Diabetes, high liver enzymes, abnormal CT, abnormal ultrasound, abnormal MR, obesity with any elevated liver tests. Right now, we know in the US, there's 100 million people with fatty liver, and it is competing with alcohol as the #1 cause of liver transplants. But usually, people who have alcohol-induced liver disease that progress to transplant have metabolic syndrome. You rarely see a thin male or female with liver disease from alcohol because they don't have metabolic syndrome. So metabolic syndrome really amplifies the risk. It can happen in thin people, but it's quite rare. 80%, 90% of the alcohol patients I see are drinking on top of metabolic syndrome and fatty liver. Okay, so let's talk about this disturbing evolutionary development. Terrible things going on, fructose, inactivity, bad genetics, microplastics, right? All these things are in plastic water bottles, not just microplastics, but bisphenols, phthalates are poisoning our entire society. And this is just a funny joke somebody came up with, but overall world prevalence is over 24%. Some people think that's as high as 30%. When I was in Africa, there were no malnourished people, and I was seeing obesity in Africa, West Africa, which is kind of the poorest section. So we have a growing crisis, high prevalence in the US. Just think about that. If 1 out of 3 people have a potentially fatal disease, everybody should get checked for fatty liver. It's just that simple. If you have fatty liver, the good news is between 7 and 15% of those patients will get cirrhosis. So not everybody with fatty liver dies from the fatty liver, but they die from heart disease, they die from stroke, hypertension, heart attack, heart failure, kidney problems. So there's no healthy obesity. It affects every single part of the body. And number 2 is cancer. Second leading cause. So first is heart, second is cancer, third is liver disease. No healthy state. This just gives you all those numbers on this slide. So we talk about cardiovascular disease. We put everybody on statins. We push the LDL less than 70. They can't tolerate statins, like a patient we had today. Their primary did a great job. They switched them to Repatha right away. We didn't have to tell them. They can have very high triglycerides. That person was over 400, I think, on their triglycerides today, which is very dangerous. We start treating pre-diabetes with metformin. Once they have diabetes, we get very aggressive about using GLP, SGLT2, and somewhat the DPP agents, but those are really the lead ones. Pioglitazone, gone. Don't use pioglitazone. Don't use the sulfonylureas. They're gone. They're out of date and should be out of state. So hopefully that message will get across. We've been sending patients back to their primary care with those ideas. Hypertension, I really like carvedilol, but the ACE inhibitors are also good. The ARBs are even better. They also are liver protective. So it's been a big paradigm shift. This is the fact that being overweight and obese in the last 10 years has now flipped. Obesity is killing many more people than malnutrition. Malnutrition in this world, where do we see it? East Africa, like Sudan, Gaza. There's some very local places that are in crisis because of war. But that's pretty much where we see malnutrition today. This just has to do with how bad and toxic foods are for people. Junk food, soft drinks, sweets, desserts, simple sugars, fructose, a poison. So we really try to change people. This is a term and definition. So now we call it MASH, MASLD, MET-A-L-D. In Asia, they're using the word MAFLD. So there's a big argument between these two, but MASH is our simple term right now. And we've gotten rid of NAFLD and NASH. We don't use the word alcoholic anymore. We don't say alcoholic hepatitis. We don't say alcoholic cirrhosis. We say alcohol use disorder. And if you have alcohol plus fatty liver, it's called MET-ALD. Those are the best terms. This is alcohol-related hepatitis, alcohol-associated steatohepatitis, alcohol use disorder. These are all the new terms that we use. MALO, major adverse liver outcomes, and MACE, major adverse cardiovascular events. These are all terms that you can see published. This is some criteria. I'm not going to go into great detail here, but right here where it says cryptogenic fatty liver, that's when we're going to do genetic testing in the clinic with our prevention genetics panel. So we're happy with that. Let's see. BMI information, glucose, blood pressure, triglycerides, HDL cholesterol. That's here also. I would be focusing on LDL more than HDL. There's some pediatric information on this slide also. Subclassification, where it's super important on this slide, is this transition of MET-ALD and the level of alcohol intake when superimposed on fatty liver, superimposed on metabolic syndrome. So we try to take a history, but more importantly, we just get PEth testing. So PEth, we need to change, I'll see the grid a little bit, add LP little a, add PEth testing, just a couple more things to help trigger, make that grid look just a little bit better. I think we've covered everything on here, just talking about fatty liver, but then you get to MASH, which is steatohepatitis. Hepatitis means inflammation. Usually when you say MASH, they have at least some level of fibrosis, at least fibrosis level 1. Some people with fatty liver can have absolutely normal liver enzymes. I think we saw somebody today that looked like that, but the scan showed fatty liver. So you believe the scan, don't worry about the enzymes. We stage these patients, of course. It does get a little confusing because when they have severe fatty liver, it overestimates the fibrosis. So somebody who's got a CAP score, a fatty liver score of, say, 360, the F score will be overestimated on the FibroScan. So we have to go back to platelet count, FIB4, APRI, just kind of look across the whole patient. These are all the different reasons that I tell patients that their life is cut short by 10 to 20 years. Sleep apnea, because we take a snoring history, look at all the cardiovascular disease, type 2 diabetes, of course, which then goes back and affects things. All these orthopedic problems, gout risk is much higher. Arthritic disease in general from just being overweight. Your joints aren't built to carry more than your body mass index target. Changes fertility, higher risk of gallstones. The asthma is probably from reflux disease. A lot of anxiety and depression that get worse as people get more obese, or the depression and anxiety is causing the eating disorder. So we really do psychiatric assessments. I mentioned at least 13 cancers are increased when people are overweight or obese. COVID-19 is worse in these patients. And of course, there can be other issues that can take place as well. This is what's called cardiovascular risk assessment. We already do that in our patients. This little graph that we use just to tell people about all the different complications that happen and why they need to get to a healthy BMI. It's a little bit of a joke. Your weight's perfect. You're just 11 feet too short. So it's pretty funny. There is no safe alcohol intake. There's been a lot of arguments about this, different studies, different study designs. We just tell people stop drinking until your liver tests are normal. We've reversed your liver disease. Then we determine if they have alcohol use disorder by doing our questionnaire and other things too. But there's no liver protection from alcohol. There is from coffee. Green tea and black tea are liver protective, so that's really a good idea. The thing on here that I want to highlight is fructose, which is in all this junk food we have, is a direct liver toxin. It kills and damages the mitochondria, which everybody needs. They're like little batteries that people have. The biome's important. The red meat junk food diet changes the bacteria. That makes the liver disease worse. If people go on a healthy diet, the liver gets better because the intestines are better. This is called lean NASH. There are thin people or normal BMI people who have fatty liver. Their problem is usually genetics, somewhat diet, change their diet, can't change their genetics. So you have to be a little bit more aggressive. I would use Resdifra in somebody with lean NASH if they're F2 or F3, because they won't have a lot of other options other than diet changes, biome changes that we talked about. It's a little bit more on lean fatty liver. People who have fatty liver have a reduced quality of life. This is an inflammatory state. It changes their whole body, how their brain works, how they sleep. A lot of this is driven by what's called visceral adiposity. So fat on your legs is not as toxic as fat that's in the belly. This is a lot of studies about GGT. Look at this. We've got 16, 23, almost 45 studies highlighting how important GGT testing is. This is really key. Hopefully we can get that to the primary care providers to do GGT testing. This is a simple 7 to stage liver disease. We look at the platelet count, AST to ALT ratio, spleen size, portal vein size, APRI, FIB4, and NAFLD score. What's not on here directly is the elastography, because a lot of people don't have a machine or don't have access to the results. But you can do all this with an ultrasound and some lab testing. Pretty amazing. ELF is a great blood test, FDA approved, cleared for staging and for prognosis. We don't do that much here because we have all these other tests, including FibroScan, but I will order an ELF test if I'm confused or I don't have access to a FibroScan or the FibroScan low quality. So ELF is just a backup test for us. Up in Santa Rosa, where I work, they still haven't bought a FibroScan. I've been arguing with them for 2 years. So I just do ELF test on everybody. So ELF is kind of my rescue up there. These are the different machines that are out there. There's something called ARFI. There's something called Velicure, which is a different type of shear wave testing. And then the FibroScans on the left. They're all good. The FibroScan has an advantage because they have a couple thousand papers written on FibroScan. The rest of these machines, might be 100. So FibroScan just has a lot more data, but they're all pretty equivalent, including the one we tested in clinic here a couple months ago. I like that one a lot. Liver stiffness. Liver stiffness should be a low score under 6. Once you get above 6, you start being worried about fibrosis, and then stepwise up to F4. The CAP score in a healthy person is under 220. Under 220, great. Over 330, severe. One thing we can do on MRI scan, and this is available at UCSD, is calculate fat, inflammation, and iron on one scan. We don't get this too much, but it's available. So a bunch of other scores out there that are interesting, but we're not going to talk about those today. We're going to screen for fibrosis in every patient with chronic liver disease. We stage every patient, and we restage them mostly yearly, rarely less. So liver stiffness, transient elastography, predicted liver failure, predicted death, predicted liver cancer. So if someone's got a high liver stiffness, especially above F3 conversion, they have a very high risk of severe outcomes. Genetic testing, which are all listed here, especially in the blue box, we don't do yet because it's expensive and nobody knows exactly how to use the information, so that's on hold. This is back to imaging, algorithms, more tests, more non-invasive tests. But I think this is really a great summary why people should be healthy. So once they get to a healthy weight, hypertension's down, glucose is down, asthma's better, dyslipidemia is better, polycystic ovary syndrome and infertility is better. reflux is better, arthritis gets better, they become urine and bladder function is better. So this is why we push so hard on this and getting to that target BMI, because these people have been sick for 5, 10, 20 years. Oh, lose 10 pounds or lose 15 pounds. That's not enough. You got to go all the way back to a normal BMI to really reverse a lot of these bad things that have happened. Fasting is okay. That works. And this just talks about what happens as you lose weight. Here is just biopsy saying that after bariatric surgery, liver gets better. And there's a lot of drugs coming. There's a bunch of drugs that are listed here. But the next big move will be GLP drugs. We'll get a label for fatty liver. Then we have to decide GLP first or Rezdiffra first. So big discussion. But what I just saw in the newspaper, one of the medical newspapers, was 25,000 emergency room admissions for GLP-1 side effects. So they're not safe in the big sense of the word. So I think that's it, because we just got a couple of moments left. This is another slide on all the drugs in development. They're going to get there. And yeah, I think that's pretty much it. There's a bunch of others. And these are all the people that gave me slides. Any questions? Did we hit everything? Elsie, all the things we wanted to focus on? Denise, Adla? I'm going to generate an email about these bullet points that you could send out to everybody.
That's great.
Thanks, everybody.
I'm wondering if tirzepatide is having the same side effects as the